Without further ado, next to diabetes, thyroid disorders are the next most common endocrinologic disorder we see in primary care. To discuss this topic, it's a pleasure to welcome to the podium a longtime friend and colleague, Dr. Roland Sakiyama. Dr. Sakiyama is a clinical professor of medicine at UCLA and a board-certified endocrinologist. Roland.
Thank you. Okay, thyroid. Let's see if we can get going. How common? You see it all the time. You're probably screening with TSH tests. If you look at a population healthy, 25,000 individuals, on average, you'll see about 11 to 12% of those patients with an abnormal TSH. Abnormal TSH. Doesn't mean they have thyroid disorders. If you kind of break it down, 9.5% have an elevated TSH, 2.2% have a suppressed TSH. But of that 9.5%, 9% that TSH was in the subclinical range. Less than 10, T4 is normal, as we'll find out a little bit later. So only 0.5 TSH was above 10 and probably had overt hypothyroidism. Well, that's still pretty good, about 1 in 200. How about hyperthyroidism? If we're just looking at TSH, 2.2% have a suppressed or low TSH, but only 0.1% actually have a real suppressed TSH in thyroid disorders, about 1 in 1,000. So you're looking at anywhere from maybe 1 in 200 to 1 in 1,000 individuals with true thyroid disorders, but you'll see the TSH abnormalities a lot more common in women than men, more common as you grow older. If you kind of look at who you should be sending to TSH, it really depends on who you want to read and who you want to believe. So these are different societies, and you can kind of take your pick. But kind of the theme is, as you're older, you want to think more about thyroid disorders and maybe screen, maybe at age 50, maybe at age 60. You probably want to think more about it in women than in men. You know, what age depends on, you know, what society you might believe in. Or you can believe in the U.S. Preventative Services Task Force, which basically says TSH screening is not helpful. And, you know, they have a case. A lot of times when the patient has symptoms and you work that patient up and treat them then, you might have the same overall outcome as if you screen. Well, who do I screen? And I do primary care as well as endocrine, and basically symptoms suggestive of thyroid disorders. So part of the talk is talking about the symptoms so that you understand them. You can have them in the back of your mind, and if you hear a couple, you're going to think about thyroid disorders. Family history of thyroid disorders. It can be either Hashimoto's thyroiditis, which is fairly common to run in families, or things like Graves' disease occasionally. Women over 50, women over 60, kind of depends again on what age group you want to do. Pregnant women, I think, actually should be screened. It's not a firm recommendation that you screen all pregnant women, but I think there's enough evidence that it may be helpful to do that one test. Finding a goiter, certainly you should think about thyroid disorders, and certain medications, probably the most common one that I'll probably see in my own primary care practice is amiodarone, cortisone, which is still used for arrhythmias, sometimes lithium. These are some of the other things that if I get in my history, my intake history, then I'll think, okay, maybe I'll send off that TSH. History of autoimmune disorders or positive antibody tests, high cholesterol, family history of thyroid disorders, certain medications, and then other things like sleep apnea. I'll think, okay, I should rule out hypothyroidism. Unexplained weight loss, I should rule out hyperthyroidism. So any of these things start to make you think, okay, I should screen. And as you send off your TSH and screen, 9.9% on average may have an elevated TSH. So we'll talk about hypothyroidism first. So these are the symptoms of hypothyroidism: weakness, dry, coarse skin, lethargy, periorbital edema, cold intolerance, memory impairment, constipation, depression, weight gain, fatigue, dyspnea, changes in menstrual period. Very nonspecific. So probably you'll see 10 patients with these symptoms who probably have maybe some mild depression or major depression versus one person with hypothyroidism. But if you start to hear a couple of these symptoms, unfortunately, you're probably going to be screening. Very common in hypothyroidism, but the overlap with other conditions that we see a lot in primary care is certainly there. Examination, honestly, it doesn't help you too much, because by the time you see someone like the patient here, the hypothyroidism has been there for a long time. So if you see someone like this, they probably haven't seen a physician or a primary care provider in quite a long time, haven't had any checkup. So if they come in and their thyroid has been underactive for a long period of time, you might see kind of the classic examination of hypothyroidism. You might have that dry, coarse skin, dry, coarse hair, as you might see there. Maybe she has a little edema around her eyes and some peripheral edema. You might even imagine a little goiter here in her neck. You do her reflexes and it's kind of slow. And you're thinking, oh, well, that's kind of the exam that I might think of hypothyroidism. But again, late findings, so that's why we rely more on screening tests. TSH you send off all the time, I know. A lot of times you do the reflex TSH, which actually I think is a good idea. Your TSH is elevated most of the time, depending on the levels. Most of the time you're dealing with primary hypothyroidism. Primary disorder of the thyroid gland, pituitary senses it, pushes up the TSH, try to make that thyroid gland work harder. But there are other things. There's interfering antibodies, non-thyroidal illnesses, and medications that can cause an elevated TSH, especially those TSHs that are above upper limits of normal, say 4.7, like my lab, to 10, kind of that subclinical range. You see them a lot, 9% of the population, and for most times, it's not primary hypothyroidism. For primary hypothyroidism, if your TSH is clearly elevated and your clinical symptoms fit, everything fits, I think you can diagnose them. But again, I think most of us will check that reflex TSH. So they send a TSH off, or you send a TSH off, the TSH is elevated, they'll do a T4 measurement for you, often a free T4 measurement. So sending the patient back for confirmation of a low T4 level often is already done for you. And so if you haven't done that, I think it's certainly appropriate, especially if the clinical picture doesn't quite fit the TSH elevation. Additional tests, usually you don't need. The antibody test you can do, but I'll tell you that they don't really help you too much with the diagnosis of hypothyroidism. And then imaging tests, thyroid scans and ultrasounds, are mainly to look at the structure of the thyroid gland like a nodule, or maybe to understand the underlying cause of hyperthyroidism. But for hypothyroidism, a scan or ultrasound really isn't necessary at all. It's mostly a laboratory test in your clinical presentation. So we see the TSH elevated, the thyroid's underactive, the T4 drops, and the reason you don't get a T3 on your reflex TSH, which is elevated, is because the T3 doesn't go down until much later, months to maybe even years later. So basically, you shouldn't waste your money on a T3 if you're dealing with hypothyroidism. It's TSH and T4 if your TSH is elevated. Now, the other tests you can do are these anti-TPO antibodies or thyroid peroxidase antibodies. So these are autoantibodies that go against an enzyme in the thyroid gland, thyroid peroxidase, which is critical for making thyroid hormone, your T4 and T3 in your thyroid gland. So if you're knocking out this enzyme, basically the thyroid is underactive, it grows bigger, i.e. you get a goiter because you're trying to make thyroid a hormone, but the factory isn't as efficient as it should be. If it's positive, you're almost always dealing with Hashimoto's thyroiditis or chronic autoimmune thyroiditis, basically two names for the same thing. The antibodies are positive in about 95% of individuals. Now, sometimes, as you'll see a little bit later, I'll do the antibodies, even if I'm not wondering about Hashimoto's thyroiditis. I might do it in a person with subclinical hypothyroidism, or sometimes in pregnant women, or women who are thinking about pregnancy, I might do it. But as a run-of-the-mill thing, I usually don't do that antibody test. What are the causes that you'll see? Hashimoto's thyroiditis, most common in primary care. Sometimes in a referral population, endocrinologists will actually see number 2 is more common because we're seeing a lot of patients that have been treated with I-131 or surgery and are hypothyroid for that. So it runs a pretty close 1 and 2 as far as the most common things that you see. There are other problems, maybe less than 5% of patients you see, a chronic autoimmune thyroiditis, which basically you don't have a goiter and your thyroid's not working, idiopathic causes of hypothyroidism. But certainly 1 and 2, Hashimoto's and or post-ablative therapy are the most common things that you see. Now, once you make the diagnosis of hypothyroidism, there's really not a whole lot more to do unless there's some other complex question associated with it. But they come in, maybe they have some symptoms, you're running your TSH, say it's 50, 150, the T4 is low. Basically, you have your diagnosis and you're now saying, okay, I'm going to treat that patient. Treatment of choice is levothyroxine, which is the brand name of things like Synthroid, Levoxyl, Unithroid, Tirosint. And basically, if you're using these medications, ideally, you want to stick with one brand. And the reason for seeing recommendations about that is that there's nothing wrong with any of the brands. It's just the absorption, the area under the curve after absorption is a little bit different. So someone who's on Synthroid and you switch them to Levoxyl, say, because their insurance asks you to switch them, sometimes it's the absorption's less or the absorption's more, and your TSH may change. So if you don't stay with the same brand, you're obligated to check their TSH after they change. Now I know, because I do primary care, a lot of times the insurance will basically say, oh, we'll cover levothyroxine, whatever brand that we happen to have a contract with, and it may change from one to another, and usually it doesn't change within a year is the only good thing. So as I look at them, their information, and I ask them, is it say Synthroid on, or does it say Unithroid? Is there some difference on there? And if there is, then certainly I would probably check their TSH. Average replacement dose is about 1.6 mics per kilogram, or about 120 mics per day for an average adult, a little bit less for an elderly patient. This is on Levoxyl, which was off the market for a while. And it wasn't a problem with the medicine. It was actually a problem with the bottle that it came in. There was an odor to it, and so it was pulled. It's back on the market. Levothyroid, which was on the market, is now discontinued, primarily for economic reasons, and then the other three brands are listed there. So as you start back on your levothyroxine, say 1.6 mics per kilogram, or maybe 120 mics, how do you start back? Well, if they're young and they're healthy, I just start pretty close to what I think their dose is. If they're real thin, I'll probably calculate 1.6 mics per kilogram. If they're kind of 67 kilograms, I'll probably just go at 100 mics, which is enough that you're replacing them and their symptoms will get better. And I know probably I'm not going to over-replace at 100. Then I'll check their TSH 6 to 8 weeks later. TSH is still a little high. I'll bump it up 112, 125. TSH is suppressed. I'll bump it down to 88, and so on and so forth. People who are older or have cardiac disease, you have to be a little careful, especially cardiac disease. You can induce angina, you can induce congestive heart failure, arrhythmias. So just be careful. Start with like 25 or 50 mics and work your way up. Actually, most people feel better even if they're under-replaced, but if you give them some replacement. So say you're giving them 50 mics, they'll actually start to feel better even though their TSH will probably still be elevated. Subclinical hypothyroidism, usually we're using a smaller dose, although as you'll see, I really try to avoid treating patients with that disorder. Your goal is normalization of the TSH. I check the TSH. Half-life of the medication's 7 days, so I'm usually checking 6 to 8 weeks later, and I want it to be normal. Normal TSH, no symptoms, everything's quote-unquote back to normal. I'll leave them on that dose. I'm not a big believer that I have to get them to the lower half of normal, but if they continue to have symptoms, I'm thinking, okay, might be related to hypothyroidism. I better start thinking of other things, though, in case the symptoms don't go away. So I wonder if they have other disorders causing their symptoms. But if they have symptoms after about 12 weeks of therapy, I'll bump them up a little bit more. This is when I try to get their TSH in the lower half of normal. For our lab, it's 0.3 to 2. That would be the lower half of normal. I try not to suppress them, though. But say if they're 3 or 4, they have no symptoms, I'll leave them alone until the next year. Now, why don't you want to suppress them? So say you put them up and they're at 112. I'm still tired, doc, I need more. Their TSH is 0.1. And you say, no, it's on the low side. They shouldn't have symptoms. But maybe, their symptoms are related. So you bump them up again. Their TSH is less than 0.1 now. You suppress them. Long-term, you can have some problems. These are long-term things, years of suppressed TSH, usually not acutely. But primarily, it's fractures, osteoporosis, especially in postmenopausal women. And so you can see that their bone mineral density on average is lower with a suppressed TSH and their fracture rate's higher. And also if heart problems, especially cardiac arrhythmias, atrial fibrillation, very common. The risk of atrial fibrillation for a person with suppressed TSH is about 3-fold higher, especially in the elderly groups. So someone who's elderly, who's on thyroid, recent onset of atrial fib, that's one of the first things that you should be thinking about. Okay, let's see if we can go. It's subclinical hypothyroidism. Now you see this all the time. So you're measuring your TSH and maybe you're screening, you have some symptoms. You see 9.5% are abnormal, but 9% of those 9.5%, the great majority, they're subclinical. Their TSH is above normal, say 4.7, but less than 10. The T4, if you did a reflex test or you happen to measure it, the T4 is normal. So T4 is normal, TSH is a little bit elevated. Basically, that's subclinical hypothyroidism, and it's not clear, although usually the symptoms are not related to the hypothyroid condition. Now, the problem with this is that the symptoms are so nonspecific, a lot of times you fall into this, I don't want to say trap, but you fall into this program where you're treating them with levothyroxine because of their fatigue or weight gain, and you're hoping that they get better. But because their TSH is really not that elevated, chances are fairly good that it's not going to get better. Randomized controlled trials say actually most patients don't show any improvement in symptoms. All the kind of endocrine societies, American Thyroid Association, American Association of Clinical Endocrinologists, basically recommend against treating that person with subclinical hypothyroidism because you don't improve symptoms. So certain arguments for treatment are they have symptoms. Well, most of the studies would tell you, no, there's no difference in the patients treated with levothyroxine, usually at 50 micrograms versus placebo. No really change in those symptoms. And what happens is that your patient is now convinced that it's a thyroid condition, and they want more and more thyroid medications to make their symptoms go away. So you have to understand that before you get into that algorithm. How about the patient's going to progress to overt hypothyroidism? Isn't it just going to get worse? Well, it does in some patients, but it's only about 2 to 4% per year. And studies have shown that if you wait until that TSH is clearly above 10, and say you're checking it every year, and you treat them then, it's really no difference from treating them and preventing them to have that elevated TSH of 10. There's no difference at all. So if you monitor them, you're fine. Now, this is one of the few times that I might use antibodies. And if your antibodies, anti-TPO antibodies, are positive, then you're thinking, okay, that person probably has Hashimoto's thyroiditis. Maybe their progression rate will be higher. And certain studies have shown the rate of progression to overt hypothyroidism is about twice as high. So some people will argue, well, that's enough for me. I'm going to put them on levothyroxine, say 50 micrograms per day for that TSH of 7 because their antibodies are positive. And I don't think that's a wrong thing to do. I think you just need to make sure that it may not cure their symptoms that they may have from, say, other disorders. When do I really consider treatment? And it's in this group. It's for the women who are either planning pregnancy or pregnant or trying to get pregnant. And so patients trying to get pregnant, they have ovulatory dysfunction. They may have anovulation. And the gynecologist is seeing them, and they're trying all these things to try to get them to ovulate and get pregnant. It's a big deal. It's a lot of money, obviously. Their TSH is 7 or it's 8. And they're sent to your primary care physician and say, will you treat this? Well, to me, if I get that TSH normal and I take that factor out of it, then the gynecologist or fertility specialist won't have that to blame. I'll just take it out of the equation. If they do get pregnant, we actually don't want a TSH that's even subclinical to be a problem, especially if they have positive antibodies, because it has been associated with some obstetrical outcomes which are not so good. So this group, I would certainly think about treating, but other than that, I really try to steer away from treatment. How about cardiac disease? And this came up about 4 or 5 years ago where the subclinical patients were thought to be at increased risk for heart disease. And this is just a study looking at this question, about 3,400 patients with a subclinical elevation in TSH, and basically there was no significant association with heart disease until that TSH again was greater than 10. So 10's kind of like that number that you should pay attention to. Pregnancy and hypothyroidism. So I would guess most of you probably don't do pregnancies. You may certainly see the patient, may help them try to get pregnant, and then once they're pregnant, probably send them off to OB or family practice. But hypothyroidism in pregnancy is a big deal. And so if you're doing primary care, it's also your concern, because the mother, in the first 12 weeks of gestation, that first trimester, is the source of thyroid hormone for the fetus. Fetus thyroid hasn't developed yet. So it's getting all its thyroid hormone for brain development and physical development from the mother. And if the mother can't provide it through the placenta, then there's going to be problems. I'm going to skip that slide for this presentation. Basically, I'm missing one slide. Okay, there's one slide in here, and I apologize for it not being in there. Basically, that's we'll give you the references for patients who have an elevated TSH and adverse obstetrical outcomes. And it seems to be with a TSH greater than 10, and also for the subclinical hypothyroidism if their antibodies are positive. Which, if you have antibodies positive and your TSH, again, is 7, certainly you should think about treating that individual. If you don't have the antibodies yet, I think you have to assume, okay, the antibodies may be positive, I should think about treating that individual. Now, where does it come in primary care? So I have a woman who's, in her late 20s, early 30s. She's on levothyroxine, say she's on 112 mics per day, doing well. She might get pregnant. So one of my instructions to her is that we need to increase your dose if you have a positive pregnancy test. Why is that? Because 85% of women who are pregnant and hypothyroid require a higher dose of levothyroxine, 85%. And most of those women require it early, within the first 5 to 8 weeks of gestation. So this is just when their pregnancy test is turning positive, they're seeing you maybe as primary care, and they want a referral for someone to cover their OB, but you should respond early. And so my patient has instructions. If that pregnancy test turns positive, I want you to increase your levothyroxine dose by 30%. Well, how are they going to do that? The easiest way is I tell them to take 2 extra tablets of levothyroxine. So for her, she's on 112 mics. She will take 2 extra tablets twice per week, 2 extra tablets, twice per week, so like Monday and Thursday. The half-life of the drug is 7 days, so taking it on a double dose on a single day is not going to make her hyperthyroid for one day. You can do that, or you can break them in half and take it every other day. But you want a 30% increase until they can get into your office and check their TSH. TSH is elevated, then you adjust again. TSH is normal, then you stay on the same dose. Now I can change her to maybe 150 mics per day, and she can take 1 per day. TSH is suppressed. She's in the 15% group that doesn't need the higher dose of levothyroxine. But these are instructions I give to my patients who are not pregnant now but have hypothyroidism so they don't run into problems. Okay, hyperthyroidism. Hyperthyroidism, I think you're happy when you diagnose this clinically because you can do it based on symptoms and you can do it on exam. When you have your presentation and you do your exam, you should feel like, oh, that patient I really think has hyperthyroidism. With a hypothyroid patient, I can send off a TSH and it's 150, and I said, wow, I didn't even think that she had hypothyroidism. This one, hopefully, you think about it according to their symptoms. Let me back up. So their symptoms: nervousness, irritability, sweating, heat intolerance, palpitation, fatigue. So they're not always jittery and shaky. They get tired after a lot of that jitteriness and shaky. Menstrual periods abnormal. Weight loss, increased appetite. I'm losing weight, but I'm eating more than ever. Wouldn't we like that? I mean, most of us would. But their metabolic rate is pumped up because of their hyperthyroid condition, and that's why they're losing weight, but they're eating as much or more than ever. Other things might be going on. Now this, you should see some findings on your exam if you're looking carefully. Hypothyroidism, probably not going to see anything. Hyperthyroidism, you look closely. You might have a tachycardia. Their skin is very warm and moist. It feels different. They might have a tremor. You put their hands out and they have a little fine tremor. They might have a goiter. You listen over the goiter, you hear bruit because there's increased blood flow in that thyroid gland. Reflexes are fast. They have other findings in other organ systems: atrial fibrillation, splenomegaly, gynecomastia. And then they have the eye findings. So back on here, my lady, you kind of look at her eyes and you have that kind of deer in the headlights look. Well, that's from increased sympathetic stimulation from the thyroid hormones, pulling the eyelids back, so they just kind of look at you. And especially if you've seen your patient before, you can just say, hey, that's not what I remember my patient looking like. That look on the left is generic for hyperthyroidism. Could be Graves' disease, could be multinodular goiter. But on your right is more the Graves' ophthalmopathy, with if it's asymmetric, is usually a lot easier to pick up. Half of them are asymmetric. This is the proptosis, the infiltration of those extraocular muscles in the back of your eyes, pushing the eye out, limiting their muscle function, and therefore they get often diplopia. So if you see that, and you're confident of that, you're probably dealing with Graves' disease. Now here, you're measuring your TSH, and if you did a reflex, the TSH is suppressed, they'll send the T4 and the T3 off for you. They'll do both because the T3 now is actually one of the more sensitive and early indicators of a hyperthyroid condition. And so the T3 comes up sooner, and sometimes it's only elevated and your T4 is normal. So your TSH is suppressed, your T3 is elevated, nothing else going on, you're probably dealing with hyperthyroidism. Your T4 may come up a little bit later if you're patient. What you see in primary care is probably Graves' disease, Graves' disease, Graves' disease. Probably 70 to 80% of your patients have Graves' disease if they have hyperthyroidism. Older patients, you're starting to see the multinodular goiters. Most of the times you can feel a goiter. A lot of times you can feel those nodules, sometimes you can't. It's just a goiter and you think you don't feel any nodules. But especially if they're older, you're thinking multinodular goiter, or you have one nodule that's hot, that's a toxic adenoma, and usually you can feel that nodule. Now, what kind of tests you can do? Well, this is where a thyroid scan is helpful. As long as they're not pregnant and they haven't taken PTU or Tapazole, which we use for treatment of hyperthyroidism, and they have no other reason that we can't give them radioactive iodine. You give them radioactive iodine orally, and you measure the uptakes at 6 and 24 hours, how much they're soaking up from their oral dose, and what does the picture of the thyroid gland look like. So in Graves' disease, or what the radiologists will call diffuse toxic goiter, you'll see the 6 and 24-hour uptakes high. First clue, and you're reading. And then if you get a picture, it'll be dark black. Or if you get the reading, it'll say diffuse uptake, or increased uptake in the thyroid gland. Diffuse toxic goiter, that basically means Graves' disease. And you major diagnosis of Graves' disease, low TSH, high T3, high T4, and a positive scan. Now with scan, the other reason I sometimes like this is it can tell me what other things might be going on. And one of the other things is a toxic multinodular goiter. Now, if I'm feeling that goiter, and especially if I feel nodules, I certainly want to scan. But on a scan in a toxic multinodular goiter, some of the nodules, maybe all of them, are hot. They have increased uptake, so they'll light up on a scan, where other parts of the thyroid gland won't light up. And the reading usually will be a toxic multinodular goiter. But it's certainly different from a diffuse homogeneous goiter or Graves' disease. And then if you have one nodule, and usually you can feel these because they're greater than 3 centimeters, and it's hot, that's a toxic adenoma. Probably about 3% of the population are patients that will present with hyperthyroidism. And that's, you feel really good when you make that diagnosis because you felt that nodule on your exam. Now, the other tests you can do are the autoantibodies for Graves' disease, because that's the number one thing that you'll see. So you can, check off the boxes on your lab. Depending on your lab, you can order antithyroid stimulating immunoglobulin, thyroid TSH antibody, TR receptor antibodies. These are the autoantibodies that sit on the TSH receptor and basically stimulate the thyroid to become overactive, and other things that make the gland enlarge usually. But basically, you can think about it as a stimulating thing that can't be turned off by the pituitary gland or the brain. And it's not the TSH, but it acts just like TSH. And you can measure them positive in about maybe 70 to 80% of patients with Graves' disease. So Graves' disease, which is going to be your number one thing that you could diagnose, if you're got the biochemical evidence, low TSH, high T3, high T4, and the eye findings you're confident of, you got a diagnosis. Eye findings not there, or maybe you're not confident, you got a positive scan, you got the diagnosis. You want to do antibodies are positive, you got the diagnosis. Antibodies are negative, you probably need a scan to make the diagnosis. So that's how you get into Graves' disease and probably multinodular goiter if you're doing the scan. Now treatment, and certainly you can do this in primary care. Don't have to have endocrine for this. Treatment primarily for Graves' disease, I-131 therapy is the treatment of choice. Outpatient, very easy, economic, very few complications. Complications, hypothyroidism, and it often depends on the dose and the number of years since they've had it. So once they get that dose, you're monitoring your thyroid test, TSH, and maybe a T4. You're expecting it to become normal, and you're happy when it's normal, but you have to worry about hypothyroidism because the radioactive iodine may have destroyed more tissue than the radiologist thought, and they become hypothyroid. Hypothyroid, then you're off to levothyroxine treatment. Now, there is a small incidence of cancer associated with radioactive iodine. And we knew this when we used radioactive iodine to treat thyroid cancer, but we didn't really think it was a problem with the doses we used to treat hyperthyroidism, like Graves' disease. But this study, which looked at about 2,800 hyperthyroid non-cancerous patients treated with radioactive iodine, did show that cancers were reported more commonly in these patients. There were about 24 more cases per 10,000 patient years. Our risk ratio of 1.25, our absolute rate of about 1 in 400 individuals that may have a cancer associated with the radioactive iodine. Cancers, as shown here, may be related to the dose. It's an oral dose that they get, so maybe more stomach cancers, maybe more kidney cancers, passes by the breast, possibly more breast cancers. So this is something that you do have to mention to your patients now as you're giving them radioactive iodine. Now, what else can you do? You can use these two drugs, methimazole or tapazole, propylthiouracil or PTU. Both of these drugs work very similarly. They block the production of T4 and T3, so your T4 levels will come down to normal. It does take weeks usually for it to work, so it's not going to happen with the first dose. Typically, I'll recheck them at 2 to 4 weeks later, and I'll expect to have them normalize hopefully within the next 8 to 12 weeks. The interesting thing, it also probably affects the autoantibody, that antibody that's stimulating the thyroid gland. So this is why sometimes you can give them the medication and stop it maybe a year to 2 years later, and they might have a remission of the Graves' disease, is because of this effects on that autoantibody. Most of the times we're using it either to get patients ready for radioactive iodine or potentially surgery, but occasionally we will use it as more long-term therapy because maybe they don't want radioactive iodine therapy. Most of the times I'm using methimazole. A couple reasons. The main reason is it has a longer half-life. So especially on maintenance, I can often get away with once-a-day dosing versus PTU, it's almost always twice a day. As you start off, methimazole, to get them normal, I'm often doing twice a day and then drop it to once a day. PTU, I'm also often doing 3 times a day and dropping it to twice a day. But just the half-life difference makes methimazole or tapazole probably the preferred drug. There is a black box warning of liver damage with PTU in children, which I think is important and probably another reason why more of us are using methimazole. The only time you don't want to use it, and for these patients I'd probably refer to endocrine, is your patient who gets pregnant in hyperthyroidism. Difficult problem for us to treat because we have to treat the patient, the woman, but we have to worry about the fetus, the baby. We can't drop her levels too low. So tricky, and so I probably refer to endocrine. The only thing on here is that in that first trimester we use PTU and then switch over to methimazole because some of the problems associated with methimazole in the first trimester. That's the only trick if you tend to use it in pregnant women. The last therapy for hyperthyroidism, this is usually the multinodular goiter patient, big goiter, often nodules. Maybe you're doing the surgery because it is big and it's compressing on things, or the patient has compressive symptoms, or maybe the hyperthyroid condition. I have had patients with Graves' disease who don't want radioactive iodine, don't tolerate medications, they end up with surgery. So it could be any of those patients, but typically the person with a big goiter is off to surgery. So how do I kind of treat patients in general? I usually tell them, okay, your options are antithyroid drugs, and I tell them, it's once a day, twice a day, so on and so forth, versus radioactive iodine, very safe as long as you're not pregnant, but there may be an increased risk of cancer. A lot of patients who choose the antithyroid drugs, I'll usually keep them on, try to normalize their T4 and TSH. If they don't go into remission after 18 months, I usually recommend radioactive iodine therapy, or if they can't tolerate the medications, then radioactive iodine therapy. Another group that you may see is the young woman with Graves' disease who is not pregnant now, because you can't do radioactive iodine then, but wants to get pregnant in the future. It's actually easier for us to deal with that if we've treated that woman with radioactive iodine, even if she's hypothyroid, because we can deal with that fairly easily. But if she's got hyperthyroidism when she's pregnant, again, much more difficult problem. So a lot of times we prefer radioactive iodine, especially if there's a pregnancy in the near future. Subclinical hyperthyroidism you'll also see. So remember, 2.2% of the population have that suppressed TSH, but only 0.1 actually have hyperthyroidism. So you might see about 2% in this group, and I'm sure you see it all the time. In this study, the lower limits of normal were 0.45. So it's not 0.1 or less, which usually your reading will say less than 0.1, which really means really suppressed, but this is kind of mildly suppressed. If you do the reflex test, they'll measure T4 and T3 for you. If it's normal, and they have no signs or symptoms, you just follow them. You don't have to do anything else. I'll get another one maybe 3 to 6 months later, depending on their clinical situation or how anxious the patient might be. Monitor them. Probably the majority, 70, 80%, will just normalize within the next year if you just follow them, often related to other medical conditions going on in that patient. If that TSH is real low, it's less than 0.1, more likely related to the thyroid than other medical conditions. So you do your T3 and T4, elevated, okay, you're hyperthyroid. Normal, you have subclinical hyperthyroidism. In this patient, you might want to think about doing a thyroid scan, because you can often pick up like subclinical Graves' disease, diffuse toxic goiter, or subclinical multinodular goiters, and then you know that there's a higher likelihood they're going to need treatment, and you can either follow them more closely or maybe even they may elect for treatment earlier on. So a scan for a TSH less than 0.1, I probably would do it a couple of times before doing a scan, but if it's suppressed and there's no other reason for it, then I'll probably do a scan. Last thing, thyroid nodules, which 5% of the population have, 5%. You're not diagnosing 1 out of 20 patients with thyroid nodules because most of them are small, and often you don't feel them. If you feel the thyroid gland as part of your complete physical examination, you'll find a lot more. If you're not feeling the neck, you're not going to find them until they complain of something. So if you take 30 seconds to just feel that thyroid area, you'll find actually a lot of nodules. Only 5% of those are cancerous, thyroid cancer. The rest, 95%, are largely benign. Adenoma, cysts, colloid nodules, lymphoma occasionally. But basically, the challenge is trying to find that 5% of patients with thyroid cancer. While in your history and physical, we always say, oh, history and physical is the best thing. Well, we found the nodule on physical examination, or maybe incidentally on an ultrasound or something. We go back to the history. Is the history really helpful? Well, not really, quite honestly. The only thing that's really helpful is that they have a history of head and neck radiation. History of head and neck radiation, so not done for acne anymore, hopefully not, but mostly it's like a patient with lymphoma who had it in the mediastinum or neck area and got radiated years ago, more increased risk of thyroid cancer, or maybe people who are exposed to nuclear accidents, and certainly people from Chernobyl who have come to the United States might be at higher risk. But other things like a family history and distant metastases you don't see too often. The thyroid cancer that runs in family is medullary thyroid cancer. Most patients don't know the cell type of the person who had thyroid cancer in the family. So sometimes you're just worried if they have, oh yeah, my mother had thyroid cancer. And you say, okay, well, it may be medullary and this person has a nodule, maybe they're at higher risk. But it's medullary, which is less common than papillary follicular. Okay, so history, is not too helpful. You do a TSH because you should, but most of the times it's going to be normal. Why are you doing it? Well, because if it's elevated, maybe that nodule you're feeling on her left lower lobe is actually hypothyroidism, and if you treat that hypothyroidism, that kind of asymmetric nodule or pseudonodule will go away. And so you measure the TSH. So occasionally you'll find someone with hypothyroidism who doesn't have symptoms. You also measure, because you're looking for the suppressed TSH, which is more common than the elevated TSH, and if you see a suppressed TSH, do a thyroid scan, you're looking for the hot nodule. Hot nodule, don't put a needle in it. It's going to come back atypical features because it's overactive. Hot nodule, almost never cancerous, and then you treat it as a hyperthyroid condition. Most of the times, TSH is going to be negative. You're still dealing with 5% of the population who have cancer, and so you want sampling. After your TSH, you're going to do a fine needle aspiration biopsy. Way back in, fellowship days in the early 80s, so we weren't wearing gloves back then. So, you can see how old this slide is. But basically, a needle goes into the thyroid nodule, and material is aspirated, and a pathologic diagnosis is given. And you can do it in your office. If you don't do it too often, I probably wouldn't recommend you do it because there is some finesse to doing it. So either head and neck surgeon, endocrinologist, pathologist, radiologist can do it. Now, as you get your results, they'll usually come back, hopefully, one of 3 ways. They'll come back malignant, which usually means papillary, medullary, anaplastic. If it says malignant on FNA, 95% of the time, at surgery, it's going to be malignant. So it's a fairly easy decision. Looks malignant, not 100%, ma'am, but fairly high. I'm going to send you to my local surgeon to have this taken out. Suspicious, 45% malignant, which is a high enough rate, it should come out. These are a little bit harder because you take the nodule out and then you may not know on frozen section if it's malignant or not. So what do you do with the rest of the gland? If it's malignant, they should do a subtotal thyroidectomy. If it's benign, they could just take the nodule out. So sometimes a little bit harder if they're suspicious. Benign, you can watch it. And I do watch it. I have them come back, I examine their neck. If I can feel the nodule easy, I feel comfortable, then I just examine the neck. If I can't feel the nodule easy, I follow them with an ultrasound. Okay, so I usually see them maybe 6 months later, and then every year I just want to check their neck, feel it, or do an ultrasound, make sure it hasn't changed. If you do that and you're careful, it's going to be less than 1% cancerous. The problem with this is this last one, non-diagnostic. 15 to 30% of FNAs will be non-diagnostic. If it was just done, with the patient on an exam table, not under ultrasound guidance, do it under ultrasound guidance. Ultrasound guidance will be more likely to get material from the nodule, just in case you missed it. So that's your usually next step. If you've already done it under ultrasound guidance and it's non-diagnostic, nowadays, and we used to always send these patients to surgery because we didn't know. If it's suspicious, malignant, or benign, because it was non-diagnostic. So usually we ended up doing two non-diagnostics in a row. I think you should have the nodule out. So it was almost an automatic go for surgery. But now you can do genetic expression, looking for mutations in the genome of these samples, and try to identify the samples that are malignant. And this study looked at 265 samples, 85 were malignant, shown at surgery, and they went back and looked at the samples and correctly identified 78 out of 85 with this new testing, which is really much better. It has a high sensitivity, so it can pick up cancers, but it has a low specificity, 50%. So if you says negative, usually it's pretty good. And these are some of the ones that you can do in your practice. Basically, you need tissues. So this is something usually done on that second aspiration. Non-diagnostic first, or if they kept the samples, you can do it. But non-diagnostic second, then I'm going to say, do some of this genetic testing to try to see who should go to surgery and who doesn't have to go to surgery. They go to surgery, okay, I have the pathology. They don't go to surgery, I'm going to monitor them and keep an eye on it, and if it grows, then I'm going to reevaluate again. So in summary, TSH, good screening test. I like it. The reflex test, I think, is helpful because you don't have to bring people back. Hypothyroidism, TSH really good. Adjust levothyroxine during pregnancy, especially in that first trimester. Subclinical hypothyroidism, I try to avoid treating because there's always someone out there who's treated someone and you keep bumping the dose and you can't get rid of the symptoms because it's depression or something else going on. And you know it and you're kind of stuck in that algorithm. Hyperthyroidism, Graves' disease, most common. It's radioactive iodine or antithyroid drugs. Both have their advantages and disadvantages. In a thyroid nodule, you're doing a TSH and then you need tissue. Fine needle aspiration and biopsy, and then you can do the interpretation as we talked about. Thank you very much for your attention and appreciate asking me to talk today.
Okay, we have time for questions. Raise your hand and we'll get you a microphone.
Yes, ma'am.
What percentage of patients will become normal thyroid of the ones who put on Tapazole when they're...
So the question was kind of Graves' disease, and you're putting them on Tapazole, what percentage will become normal? Probably it's high, like 95%. You can get almost anyone with Graves' disease normal with a high enough dose. The problem is, can you keep them normal? Yeah, so say, and it's somewhere, you keep them on it for 12 to 24 months. I usually use 18 months. I split the difference. I try to adjust the dose so their T4 is normal, number one. Once their T4 is normal, I adjust the dose to try to get their TSH normal. TSH, T4 is normal, I leave them on 18 months, I stop them. Probably about 40 to 50% will have a remission. That means 50 to 60% won't. They go up, they can either go back on medications or do the radioactive iodine. I prefer the radioactive iodine. If they stay in remission, 40, 50%, I say, okay, looks good, let's check in 3 months, let's check in 6 months, let's check every year.
How do you address a patient with a low TSH, low free T4, so maybe low normal, maybe 0.9, 0.8, and no antibodies?
Yeah, low TSH, low T4, you're thinking, if it's true, which it probably isn't, but if it's true, you're thinking the pituitary is not working because the TSH is low. So then you're thinking hypothalamic or brain. Most of the time, it's the T4 that's throwing you off. And the T4 is really normal, but it's on the border of normal, like 0.8, say. So I would just follow that patient out, and probably it's good to the T4 is going to come up, and I would say 70% the TSH is going to normalize. If the TSH stays low and the T4 is truly low, I think you need to look up at the hypothalamus pituitary area.
Once the patient started increased dosage after the pregnancy with hypothyroidism, when do you go back to the normal original dosage? Just after delivery, or just after delivery, or some?
I missed the question. Hypothyroidism. When do I?
Woman who had pregnant, so increases dosage to adjust the TSH level.
Oh, with the pregnancy?
Yes. When do you go back to original dosage? Second
Yeah. So
question.
as soon as they deliver, they can usually go back to the pre-pregnancy dose. But it usually, and some of the people who are low initially actually will become more of a problem. Their TSH will go up in the second and third trimester. So after you find that they're low, you actually need to follow them probably like every 4 to 6 weeks. And so sometimes you're adjusting the dose higher. Maybe it's not as critical in the second or third trimester as the first, but you may find the dose. And then their instructions are usually, once you deliver, the next day you can go back to your pre-pregnancy dose.
Okay, and second question is, after the cancer surgery, there must be some suppression of the TSH level for each of the pathology or risk of the recurrence. Is there certain goal or target range of the TSH to suppress down the recurrence of the cancer?
After surgery, for
thyroid
cancer?
Yes.
Yeah, so it depends on the cancer. If the cancer is greater than 2 centimeters, or if it invades local structures like lymph nodes, you want to get that TSH fairly close to 0.1. You want to almost be suppressed, but not quite suppressed. If it's less than 2 centimeters and lymph nodes are negative, you can go lower half of normal, like 0.3 to 2.5. Okay, but if it's kind of aggressive, as we would say, then I'm going to go between 0.1 and 0.3, which is a lot more difficult to get to because, 0.1 is just a difficult range to do. But aggressive, nearly suppressed, not aggressive, you can go lower half of normal.
Thank you.
Hi, is there a role for steroids in treating Graves patients who are about to undergo radioactive iodine if they already have existing exophthalmos?
Well, so patients who are going to undergo radioactive iodine, one of your risks is that you throw them into thyroid storm. So you're giving them the radioactive iodine, you're causing inflammation of the thyroid gland, it throws out T4 and T3, and then maybe they go into storm, which is high T4 and T3 levels with CNS symptoms. So one of the questions have been, if you pre-treated them with steroids, will you prevent that? And the answer to those questions are no, you actually don't prevent it. So we don't give them steroids.
Not so much for the storm issue, but for the
eyes?
ophthalmopathy, yes.
Yeah, so for storm, you don't. Now, for eyes, it's a different question, because if you're dealing with eyes, a lot of times you are using steroids for the eye symptoms, especially if they're fairly severe. But it's not that you're treating the thyroid. You're really working with ophthalmologists to hopefully prevent more of the increased pressure and loss of vision. So that's what the steroids are most commonly used for. Well, one last one, Dr. Kwan says. Yes?
How do you treat a cardiac patient who's on amiodarone, cannot come out of it, and whose labs showing high free T4 and low TSH? Do you treat them as?
Yeah, amiodarone and hypothyroidism is fairly straightforward. You just give them levothyroxine, and I don't have a problem with the amiodarone. Amiodarone sometimes will make you hyperthyroid. That's a big problem because the hyperthyroid condition is very difficult to treat. So, and because they have heart problems, we'll typically give them antithyroid drugs, trying to get their T4 and T3 down. That one, I would say, is about 60% that they'll get better with the antithyroid drugs. So sometimes if the amiodarone is like a critical drug and I can't get them close to normal with drugs, that person I may send for radioactive iodine therapy because I can't get them off amiodarone. The problem with that is the amiodarone sometimes blocks my radioactive iodine uptake. So it could be a difficult issue, and some people have even gone to surgery for that. But hyperthyroidism and amiodarone, not an easy problem, and I probably say, you should refer off because it's not a clear answer what you should do. I don't want to see them. They're hard.